over to Dr. Reinhardt MD to introduce today's speaker. Thank you, Reinhardt.
Thanks, Oyeri. It's a real honor for me to introduce Sam. I've had the very good fortune of working with him over his years here during cardiology fellowship, and it's really been a pleasure. And I think his academic activities really speak for themselves, and I'm glad that he's going to have a chance to kind of share some of his work today. So Sam, of course, is currently doing his fellowship in advanced cardiovascular imaging with us. He originally hails from Minnesota. I had to give him a little flack for his choice of sports teams, but he was expecting that. He completed his undergraduate work right here in New Haven at Yale, where he was elected to Phi Beta Kappa, and then went to medical school at WashU, where he was elected AOA. He stayed on at WashU and Barnes-Jewish for his internal medicine training, where he was the 2015 recipient of the Tom Steinberg Award for Excellence in Research. We were then very lucky to have Sam join us for cardiology fellowship, where he also served as co-chief fellow and was a member of the team representing Connecticut in the National ACC Fellows in Training Jeopardy competition. His career interests include cardiovascular imaging, particularly echo and cardiac CT and MR, advanced heart failure, global health, and developing strategies to improve quality of life for patients through outcomes research. Again, as I said at the very beginning, I've had the very good fortune of working with Sam, and I'm really delighted, that he's here for cardiology grand rounds. And Sam, we're very much looking forward to your talk. So over to you.
Great, thank you very much for that introduction. So my talk today will be to take you all through a few of the projects I've had the chance to work on during fellowship here at Yale under sort of the large umbrella of heart failure, and showing you how we've used different types of large data sets to help answer different types of questions in clinical heart failure. And just go through a short outline for today. I'll start with a short introduction of my background for those of you who don't know me, and then go through a few different types of data sets looking at the projects we've done with them. First, a large administrative data set focusing on atrial fibrillation in heart failure. Next, looking at a clinical trial, and we examine that to look at loop diuretics in heart failure. And finally, looking at a national registry and how the organ allocation system changed for heart transplant affected patients on the transplant list with LVADs in place. And so to start, like Dr. Desai said, I hail from Minneapolis, Minnesota. This is a picture of the beautiful skyline with the Mississippi River in the foreground. And as he also alluded to, I grew up a fan of the Minnesota Vikings, the Minnesota Twins, and the Minnesota Timberwolves, the playing facilities of which are all visible in this photo. I came here for undergraduate. I was an honor marshal at graduation, and the main benefit of that was a close-up with Handsome Dan. And then, like he said, went to WashU in St. Louis for medical school and stayed on at Barnes for my residency. And during my foray, St. Louis was my net, and my wife, Tori Westovich, is also house staff here at Yale in the OB-GYN department. And then finally here, back to New Haven, old stomping grounds for cardiovascular fellowship. And like he said, now I'm staying on, having graduated my general fellowship just at the end of June here. I'm staying on for an additional year of imaging fellowship focusing on echo and CT-MRI. And so on to our first project. So looking at a national administrative data set. And our focus here was atrial fibrillation and heart failure. And so just a little bit of background, as you all know, atrial fibrillation is a common arrhythmia. For those of European descent, the lifetime risk is about 1 in 3 of developing atrial fibrillation, slightly lower for African Americans, 1 in 5. And there are several risk factors I've listed here, some of which are modifiable, others of which are not modifiable. And prevalence over time has been rising, and this is likely due to a couple of things, both increases in risk factors over time, but also patients are increasingly under surveillance and we're catching it more frequently. The estimated population in the US with atrial fibrillation was 5.9 million patients in 2010, and that's expected to rise to 12.1 million by 2030. And the prevalence is also doubled over a 15-year period in the Medicare population. so on the rise. And particularly when looking at heart failure patients who have AFib, it's the most common arrhythmia among these patients. And the prevalence and incidence both increase as the severity of heart failure increases as well, from very low prevalence among asymptomatic patients to almost half of class 4 patients. And this is a graphic from a meta-analysis from several years ago showing sort of that dose-response relationship of heart failure symptoms and the likelihood of atrial fibrillation. And particularly AFib, when present in patients with heart failure, it portends a poor prognosis. However, it's unclear if it's truly an independent risk factor or just a marker for sicker patients. And I'll go through a couple studies here looking at that. There was a 2005 secondary analysis of data from the COMET trial, which looked at carvedilol versus metoprolol succinate in heart failure patients. In an unadjusted analysis, you can see here on the survival analysis, the dotted line is atrial fibrillation patients in the trial, and the solid line is patients without atrial fibrillation. You can see the curves separate relatively early. This is for all-cause mortality, and stay separated up to 5 years of follow-up with a relative risk of 1.29 for mortality. But when adjusted just for age and gender, those differences were no longer significant. And then another analysis in 2014 using Get With The Guidelines heart failure data as well as Medicare claims data showed that pre-existing atrial fibrillation in fact did have a higher risk of outcomes at 3 years, even in adjusted analysis that included all-cause mortality, all-cause readmission or heart failure readmission. Those patients were initially enrolled based on an index hospitalization in that study. But interestingly, looking at this survival curve, blue is patients without atrial fibrillation. Gray is patients with pre-existing atrial fibrillation before that index hospitalization of interest in the study. And those two curves obviously separate. However, the red curve is patients who had new onset atrial fibrillation during the index hospitalization of the study. And those curves were not significantly different in terms of mortality. So pre-existing AFib was a poor prognosis, but new onset AFib, not necessarily. And when we look at treatment of AFib in heart failure patients, I'm just going to run through a couple of trials from recent years. We have the atrial fibrillation and congestive heart failure trial that was published in the New England Journal in 2008. And it randomized patients with HFrEF and a history of AFib to either rhythm or rate control. The rhythm control group had a preferred drug of amiodarone, though sotalol or dofetilide could be added as needed. And the rate control group was prescribed beta blockers and digoxin with the heart rate goals listed on this slide. With the primary outcome of cardiovascular death, and long story short, there was no difference even at 5-year follow-up. So looks like equivalence, at least, of these two approaches in patients with heart failure, at least as of 2008. And then in the CASTLE-AF trial, which was published much more recently, and many of you are probably familiar with, smaller group of patients with reduced ejection fraction, functional heart failure, symptomatic atrial fibrillation, and also who had Biotronic implanted devices for definitive monitoring of atrial fibrillation recurrence and burden. They were randomized to either catheter ablation or medical therapy for atrial fibrillation, and approximately 30% of those patients received a rhythm control strategy based on the discretion of the prescribing physician, and the other 70% received rate control strategy. And the primary endpoint in this trial was a combined all-cause mortality and heart failure hospitalization. And you can see here on the Kaplan-Meier curves that the ablation group did better. They had a lower risk of those outcome, or that combined outcome rather, and with a hazard ratio of 0.62, and that the curves continued to separate up to 5 years of follow-up. And the secondary endpoints, which includes the individual components of the combined endpoint, all-cause mortality and worsening heart failure hospitalization, also were statistically significant with hazard ratios approaching 0.5. And so it was in this context that we wanted to take a look at the landscape of atrial fibrillation in heart failure in the United States. There's new discussion about what are best treatment practices for heart failure patients with AFib, and we sort of anticipate that that will drive practice patterns to change in coming years. And we thought that having a good snapshot of the current landscape on a national level would be helpful to start and see where things go from here. And we also wanted to compare trends of patients with reduced ejection fraction as opposed to preserved ejection fraction, because this hasn't been looked at closely in the specific atrial fibrillation population to date, and to see if there were any disparities. And so we turned to the national inpatient sample, which some of you may be familiar with. It's the largest, in fact, available publicly available database of inpatient admissions in the United States. And contains weighted data for more than 35 million hospitalizations per year. It includes information like demographics, a patient's zip code, which can be a surrogate for socioeconomic status based on median income in that zip code, as well as payer status, ICD codes. It's primarily an administrative database, so ICD codes are what drive a lot of the diagnoses, and then also includes some outcomes, including hospital charges, inpatient mortality, and discharge disposition. And the reason we were interested in it is because it provides a look at the national landscape without any selection bias. This is designed to capture all hospitalizations at non-federal hospitals. And so the title of our project was National Trends in the Burden of Atrial Fibrillation During Admission for Heart Failure. And we used data from NIS from 2008 to 2017. And we looked at all adult admissions who had a primary diagnosis of heart failure, but also had a secondary diagnosis of either atrial fibrillation or atrial flutter. We had a primary cohort, which included all heart failure patients, but also did subgroup analyses looking at patients with reduced ejection fraction and preserved ejection fraction. We examined trends over time of clinical and demographic variables. We also performed a simple logistic regression to see if there was an independent association of atrial fibrillation with inpatient mortality, and also looked at hospital charges adjusted for inflation. And so our cohort included over 10 million patients who were admitted for heart failure during our study period, and 4.25 million of those had comorbid atrial fibrillation or flutter. We saw in demographic trends that patients with atrial fibrillation compared to those without in heart failure patients were older, they were more likely to be white, and less likely to be Black or Hispanic. When we looked at HFpEF, we saw similar trends. Patients are older when they have atrial fibrillation, and also HFpEF patients in general are older than the overall cohort at large. Also, the HFpEF subgroup, similarly, atrial fibrillation patients were more likely to be white, less likely to be Black or Hispanic, but also the HFpEF subgroup was more likely to be white and less likely to be Black or Hispanic than the overall heart failure cohort. HFrEF, we saw similar trends when comparing atrial fibrillation to no AFib, but the overall group, HFrEF group was younger than the overall cohort and less likely to be white, more likely to be Black or Hispanic compared to the overall cohort. This graph, first want you to focus on the blue bars and the y-axis on the left. This is total volume of heart failure hospitalizations in the United States by year. And you'll see from 2008 to 2012, there's a slight decrease over time, but then in 2013, the trend upward begins and continues through the end of our study period for a net overall increase during our study. And then second, if we look at the orange line and the y-axis labels on the right side of the graph, this is a representation of the proportion of heart failure hospitalizations that year with comorbid atrial fibrillation. And you'll see that there is a slow and steady rise through the study period up to approximately 45% by 2017. This is a similar graph looking at proportions of atrial fibrillation or proportion of heart failure hospitalization affected AFib, broken down by subgroup. Gray is our HFpEF subgroup, which had the higher prevalence. Blue is the overall cohort, and orange is the HFrEF subgroup, so slightly lower there. But all three increase over time. Average age over time decreased. Again, HFpEF is in gray, so that's the oldest group. Overall is in blue, and HFrEF subgroup is in orange, so all three decreasing over time. We saw decreases in female sex over time in terms of proportion of patients affected. HFpEF was a majority female group, but decreased over time. HFrEF started as a majority male subgroup, but then the proportion of males also increased over time as females decreased. And then when looking at racial and ethnic background, the percent of white patients affected decreased over time for all three subgroups. And conversely, the percent of Black patients and the percent of Hispanic patients increased over the study period. Comorbidities over time saw significant increases, including hypertension, diabetes, vascular disease, obstructive sleep apnea, and obesity, all of which have connections to risk for atrial fibrillation. And we also use the administrative coding data to calculate CHADS-VASc scores for the patients, which hadn't been done before in the literature, and what served as a surrogate for comorbidity burden, and we also saw that increase over time. When it comes to outcomes, we saw higher inpatient mortality among heart failure patients who had atrial fibrillation compared to those without. This was true for all three subgroups, or the overall cohort, as well as the two subgroups. We also saw lower rates of discharge home as opposed to skilled nursing facility or home with home health as compared to patients without AFib, approximately 13% absolute lower risk of going home without services in all three groups. And then finally, we saw higher hospital charges among atrial fibrillation patients compared to those without, with the HFrEF subgroup being the most expensive of the three. And this is a graph showing charges over time, and these are again adjusted for inflation to 2017 US dollars, and all three groups saw increases over time. And then finally, as I mentioned, mortality was higher for patients with atrial fibrillation. And so we adjusted for age and comorbidities with a simple logistic regression, and we saw that this was significantly associated with higher mortality, with the odds ratios listed for you there. And so our key findings from this study were that the proportion of heart failure admissions with comorbid AFib is rising. AFib is more likely to affect heart failure patients who are white, who are male, and who are older. However, over time, we see that the proportion of Black and Hispanic patients are increasing, and the proportion of male patients is increasing further. Average age decreased over time, which was sort of a surprise for us. We were thinking that given increased age is a risk for atrial fibrillation, and that the population is aging, that we thought that was going to be increasing over time, and in fact it decreased. Atrial fibrillation is associated with higher inpatient mortality in heart failure patients. The comorbidity burden is rising, as are costs. And so to take a step back and sort of think more a little bit abstractly about what are the benefits and drawbacks of using a national administrative database for this sort of a study. Strengths include we have very large numbers. I mentioned it covers more than 35 million hospitalizations per year, and our cohort was over 10 million patients. There's a lack of selection bias. This is taking all comers in the United States who go to non-federal hospitals, so I guess a little bit of bias against veterans potentially, but otherwise taking all comers. And we have access to bigger picture questions as a result, like what do things look like on a national level? In terms of weaknesses, we only have inpatient data. And so there's no way to track individual outcomes post-discharge. There's also no way to track individual patients. The data points in NIS are associated with admissions rather than patients. And so there's no way to see if an individual patient was readmitted. And there's little info, because it's an administrative database, little info on treatments or testing that patients receive in the hospital. So we don't know the medications they received. if they received an echo or a cath, for example. And it relies heavily on ICD-9 and 10 codes for the comorbidities, but using these codes has been validated in the literature. Okay, moving on to the second study I'll be going through with you today was looking at loop diuretics in patients with reduced ejection fraction using a clinical trial data set. Many of you are likely familiar with the GUIDE-IT trial. It stands for Guiding Evidence-Based Therapy Using Biomarker Intensified Treatment in Heart Failure Study. And it was a prospective randomized trial of patients with reduced ejection fraction who also had elevated BNP levels and a recent heart failure event, seemingly marking them as higher risk patients. And the enrollment was from 2013 to 2016, so relatively modern medical therapy for heart failure was available to these patients, and they were enrolled at 45 sites in the United States and Canada. And patients were randomized to either an NT-proBNP guided strategy where patients would receive routine lab measurements, and providers were encouraged to intensify medical therapy based on those values versus just usual care for heart failure. And there was a combined primary endpoint of time to first heart failure hospitalization or cardiovascular death. And spoiler alert, it was stopped for utility after less than 900 patients had been enrolled. And this is the Kaplan-Meier curve for the primary endpoint. You'll see that there was very little separation of the curves and certainly nothing significant even at 24 months of follow-up. However, we were interested in using the Dataset. It's currently publicly available through BioLink, which is a repository that's maintained by the National Institutes of Health for publicly funded datasets. And it's highly phenotyped with significant information on patients, including demographics, clinical data, laboratory values, also lots of information about medications and doses over time, as well as outcomes, including mortality and hospitalizations. And so our research group felt that using this data set was sort of ripe for answering more nuanced questions in heart failure. And we did a few projects, some of which I'll mention here. We looked at outcomes and trends in patients who had ischemic versus non-ischemic cardiomyopathy in this cohort. We also looked at differences in practice patterns and outcomes in patients who had been enrolled in the United States versus those enrolled at the Canadian sites. And then the project I'll discuss for you today, and the one that I sort of led, is looking at loop diuretic choice and how that impacted the patients in the trial. And so just a little bit of background, as many of you know, for patients in heart failure who are on loop diuretics, furosemide is by far the most common choice. However, torsemide has a more predictable oral bioavailability. Furosemide has a very wide range. And for that reason, torsemide is considered by many to be a better choice for higher risk patients who are more diuretic resistant or more likely to come back to the hospital. However, there are few data from randomized trials comparing loop diuretics in heart failure patients with hard outcomes. I'll go through a couple of them here for you. One of them, published in 2001, was open label, about 250 patients in the United States. Both centers were in Indianapolis, and they were recruited during a heart failure admission and followed for 1 year. This was in the late 90s, to give you a perspective about what sort of medical therapy was being used. And the torsemide group at 1 year follow-up was found to have lower heart failure readmissions and greater improvement in subjective fatigue. In 2003, there was a study published from 57 Swiss centers, a similar size, and these patients, however, were not necessarily HFrEF patients, just had symptomatic heart failure. And they were recruited as outpatients with 9 months of follow-up, but similar era in terms of medical therapy that was available. And the torsemide group in this trial had higher rates of improvement in their New York Heart Association functional class and fewer urinations, which contributed to both patients and providers seeing it as having higher tolerability, but there were no changes in hospitalizations. Another large study comparing torsemide and furosemide was the Toric study, which was not randomized. It was an open label observational study in Spain, but with a larger group of almost 1,400 patients. Again, not with verified ejection fraction necessarily, but symptomatic heart failure. And enrolling physicians would take patients in pairs who were matched by age, sex, and functional class, and give one of them torsemide and the other could have any other diuretic or diuretic combination. And they were followed for an average of 9 months. And torsemide was associated with lower mortality and higher functional class improvement. And then finally, a 2020 meta-analysis, including over 19,000 patients, showed that patients treated with torsemide generally had higher rates of functional class improvement. There was a signal for lower cardiovascular mortality when patients taking torsemide, but this difference didn't persist when they only used randomized data. And there was a trend, again, not significant, however, towards lower heart failure hospitalizations in the patients taking torsemide. So moving on to our analysis, using the guided data set, we took guided patients who were taking scheduled loop diuretics at randomization and excluded those who were not taking one or who were taking one only as needed. And we used the same primary outcome as the trial. Time to first heart failure hospitalization or cardiovascular death. Secondary outcomes we examined were those individual components of the combined outcome, and then seeing about switch of loop diuretics at 90 days. We also did a survival analysis using Cox proportional hazards regression, controlling for all of the variables I've listed there to try and see if loop diuretic was independently associated with the outcomes of interest. And so our results, we included 834 patients, the vast majority of whom were on furosemide, a smaller group on torsemide, and a very small group on bumetanide. And for that reason, I'll focus primarily on comparing furosemide and the torsemide groups here for our purposes today. Patients who were on torsemide were more likely to be Black, to have chronic kidney disease, and to have atrial fibrillation. They were on higher baseline diuretic doses, in fact, more than double in terms of furosemide equivalents. They were slightly larger in terms of body mass index, had higher serum creatinine, higher serum BUN, and also had lower serum sodium. And they had lower rates of ACE inhibitor, either ACE inhibitor or ARB, and beta blocker prescriptions at baseline. However, at 90 days, that difference was no longer statistically significant. And here's a histogram showing those medical prescriptions at baseline. And I'm focused primarily on the red and blue bars here. Blue is furosemide on the far left, and red is torsemide. And so you can see lower rates of ACE inhibitor prescriptions, no difference in angiotensin receptor blockers, but when we look at them combined, there's a significant difference here. This difference, in fact, was statistically significant in beta blocker use, and MRAs, there was a signal for higher use among torsemide patients, but this did not reach statistical significance. When we looked at our outcomes analysis, for our primary outcome with furosemide as the reference, the torsemide and bumetanide groups were both at higher risk for the combined primary outcome of heart failure, hospitalization, or cardiovascular death, with the hazard ratios listed there. And then looking at the individual components, cardiovascular death, also higher risk, as well as heart failure or hospitalization. But when adjusting for the numerous variables that I listed on the prior slide and listed below here, only 2 of those differences persisted. And that was cardiovascular death in the torsemide group and heart failure hospitalization in the bumetanide group. And this is that depicted as a forest plot. And so our key findings in this study were that at baseline, patients on torsemide and bumetanide appear to be a sicker group. They have worse lab values, they have higher BMIs, they have lower rates of medical therapy for heart failure. And so it's probably not surprising that outcomes are worse in these patients. However, these differences persisted after adjustment in our Cox regression. We understand that there still may be some additional confounders. And so we're doing some additional analyses that are in the works currently, doing inverse probability of treatment weighting, which is a method that helps, or attempts rather, to account for the non-random assignment of loop diuretics with inverse weighting, and then propensity matching, where we look at patients who have similar baseline characteristics and compare them across the diuretic groups. And so again, stepping back to think more sort of in the abstract sense about the advantages and drawbacks of using a clinical trial data set for research. Strengths include that it's prospective. These patients are followed prospectively. We have lots of clinical data points. These are highly phenotyped patients, and we can say a lot about what happened to them. We have information about the specific treatments they received and their durations in terms of medical therapy. And we have highly reliable adjudicated outcomes. Weaknesses include much smaller numbers. As you know, our cohort for this study was 834 patients compared to 10.3 million for the first study I discussed. There's some selection bias with any clinical trial. And then finally, it's not necessarily reflective of the real world. These are patients who are receiving a lot of attention, a lot of clinical care, more so probably than patients in the community. And I just wanted to give a quick shout out. So obviously we were trying to do a secondary analysis of a pre-existing clinical trial data set, but there is an ongoing randomized clinical trial that's being led by Dr. Velasquez as the primary investigator, called the Transform-HF trial. And that's looking at torsemide and furosemide in heart failure patients. And they're randomizing patients in a pragmatic clinical trial in 50 US sites with a primary endpoint of all-cause mortality. And interestingly, following patients primarily over the phone with no in-person study visits, trying to sort of replicate more of a real-world scenario. So we'll be very curious and anxious to hear those results when they come out in the near future. All right, and then moving on to our third study, looking at a national registry and how we can use that to examine the effects of the new heart allocation system on LVAD patients. And I should mention that this study was primarily driven by Dr. Clancy Mullen, who's one of our excellent CT surgery residents, who's a member of our research group. And so as many of you are probably familiar with, in 2018, October specifically, UNOS made a large change to the donor heart allocation system that determines who gets a transplant. In the prior system, there were only 3 urgency statuses: status 1A, which was the highest, status 1B, and status 2. And in the new system, they separated these patients out into 6 different statuses based on urgency. And this allowed for a lot more granularity in terms of seeing which patients were really sicker and really needed to be transplanted sooner, whereas the prior system had lumped a lot of patients in very different clinical scenarios into the same status. Also, a significant change was that status 1 and status 2 patients are given higher priority for organs within 500 miles of their transplanting center, even if that organ comes from outside of their OPTN region. And this was hoping to address the fact that under the old system, there was significant wait list time differences when you looked across different regions. And this was hoping to try and alleviate some of those differences. Durable LVAD patients under the old system were previously defaulted to status 1B in terms of urgency, but they could be uplisted for a 30-day period at the discretion of the listing physician without any other, there was just a discretionary choice to be able to do that for 30 days without any other reason. And they could also be uplisted for worsening clinical status, and it was termed life-threatening conditions. Under the new allocation system, however, they are status 4 by default, and they can still be moved up for worsening clinical status, but there's more granularity and more specific specifications for which status they should move to. So for example, a driveline infection, chronic infection can move a patient from status 4 to status 3, but they don't automatically jump to the highest status as they did under the prior system. And so we wanted to take a look at the UNOS registry, and they're termed the STAR files, which is the large registry that includes both organ donors and patients who are listed for transplant in the United States. And if patients eventually receive an organ, then they are followed post-transplant, and post-transplant data are collected and recorded. The participation in this registry is required by transplanting centers. And so this helps to ensure low rates of missingness of data and also reasonably good follow-up. However, this obviously only includes a small proportion of the heart failure population in contrast to the first study I discussed, but it is clearly a very resource intensive and clinically sick population. And so they sort of deserve our attention. And so our analysis wanted to focus on patients who had LVADs pre-transplant and see how outcomes changed over time before and after the allocation system change. And so our inclusion criteria were adults with durable continuous flow LVADs at the time of listing, or who had one implanted while listed for transplant between April 2017 and April 2020. And the reason for those dates were that it allowed us to have 18 months on either side of the allocation system change. And so we had a pre-cohort and a post-cohort. We excluded patients who received some form of other mechanical support while listed, so that patients who received an RVAD or needed ECMO or a balloon pump support were excluded. And we also excluded patients who were actively listed on the transplant list on the day of the change, because we weren't sure how we'd be able to tease out the effect of the system change on those patients. Patients were censored at the time of transplant, or if they were removed from the transplant list for recovery. Our primary outcome was looking at waitlist survival, but we also looked into how long patients waited for transplant, the ischemic time and distance traveled for the organ, and post-transplant survival at 1 year. And looking at our results, we identified almost 1,800 patients who met our inclusion criteria. Slightly larger group was in the pre-cohort than the post. And again, these all had durable continuous flow LVADs. We did not see any changes in age, race, sex distribution, or comorbidities before and after the allocation system change. There was, however, a slight increase in body size and a slight shift in blood group distribution, with type O being slightly less common in the post cohort. We, however, saw a very large decrease in LVAD patients listed for transplant change, with 102 patients being put on the transplant list in April of 2017 with an LVAD in place, compared to only 12 at the end of our study period in April of 2020. The number of LVADs implanted in a patient listed for transplant on a monthly basis decreased from 21 in April of 2017 to 0 in April of 2020. All of the OPTN regions saw decreases in the total volume of transplanted patients who had LVADs in place. And patients who were transplanted from an LVAD were receiving more high-risk donors or donors who had hepatitis C positivity in the post period when compared to the pre. We also saw that patients in the post period had longer ischemic times and traveled farther. When we look at status at listing and transplant, we'll focus first on the top, which is the pre-cohort. And on the left, that's status at time of listing. And so you can see the majority are in red, which is status 1B. That was the default for durable LVAD patients at the time. And the 5.8% who were status 2 had not had an LVAD implanted at time of listing. However, by time of transplant, more than 75% were listed as status 1A, whether that was for the discretionary 30 days that they could use sort of for free to be uplisted, or whether that was for decrease or deterioration of clinical status. We are not able to tease out, but in any case, urgency or status increased significantly by the time of transplant. If we now focus on the lower two bars, on the left, this is the post period at time of listing. And we see the purple is the default for durable LVAD patients, status 4. And already a significant number are higher status, likely due to some extenuating circumstance in their clinical condition. And by the time of transplant, we see a similar trend where patients are moving up in urgency before they get transplanted. And under the new system, this is more likely to be due to deterioration of clinical status rather than uplisting for the discretionary 30 days. When looking at volumes over time, this is our central figure from the paper. The blue line on top represents the number of patients with an LVAD in place who were placed on the transplant list in that month. And the red line below represents the number of patients who were listed for transplant who had an LVAD placed in that month. And you can see maybe a slight trend downward in the blue curve over this time period, but the red curve remains relatively stable. And this is the pre-period here, leading up to the dotted line, which is the allocation system change. But then when we look at the post-period, we see a really dramatic drop-off in numbers for both groups. So the number of patients who have LVADs in place, who are being placed on the transplant list, is going down. And like I said, by April 2020, the number of LVADs placed in patients on the transplant list had reduced to 0. When we looked at outcomes, we saw that waitlist time decreased in the post period before patients received a transplant. It went from 82 days to 65 days with wide interquartile ranges for both. There was no difference in the 1-year waitlist survival estimates in the pre and post period. In fact, it was slightly higher in the post period numerically. And we did a competing risks analysis that showed there was no change in likelihood of one of 4 or any of the 4 possible outcomes: survival on the waitlist, death, transplantation, or recovery when comparing the pre and post cohorts. However, when we looked at post-transplant outcomes, there were significant differences. There was worse 1-year survival in the post era. You can see 83% versus almost 92% in the pre era. And this is likely related to the fact that there was more graft failure, almost double in the post era compared to the pre era. In our multivariate Cox analysis, looking for survival, we saw that being in the post era was associated with worse survival, with a hazard ratio of 2.0. And the only other independent factors that we found associated with worse survival were ventilator support required pre-transplant and increased ischemic time. And this is a Kaplan-Meier curve showing the pre-cohort in blue and the post-cohort in red with post-transplant survival. And you can see that the curves separate relatively early and continue to separate up to 1 year of follow-up. And so our key findings from this study, we saw that transplant volumes for patients with LVADs have declined, and this is likely related to lower urgency status. The likelihood of getting a transplant when listed with an LVAD was unchanged, and in fact, the waitlist time was shorter. However, patients were receiving organs with longer ischemic times and who had traveled longer, and they were also receiving hearts from higher risk donors and more donors who had hepatitis C. Post-transplant outcomes appear to be worse in the post era for patients with LVADs. They have lower 1-year survival and higher graft failure. And as such, we propose that the paradigm of bridge to transplant LVAD has really shifted in the post era, and patients need to be counseled as such when consideration is being given to either LVAD or listing for transplant, or both. And so again, taking a step back to think more abstractly about what are the benefits and drawbacks of using a large registry like this for a clinical study. Strengths include that this is real world data. So these are patients who are out in the community. Obviously, patients who are on the transplant list or who have been previously transplanted generally get a little more attention than your run-of-the-mill heart failure patients, but they're still out in the community living their lives. It's prospectively managed, so we're following patients over time. A low degree of missingness, thanks to the required nature of participation. And it's not quite as detailed in terms of patient data as a clinical trial data set, but there is still a good amount of clinical data as patients are followed over time. Weaknesses include that it's a very specific patient cohort, so it only includes patients who've been listed for transplant or have received a transplant, so clearly not widely applicable to all heart failure patients. And as such, it limits the clinical questions that can be asked and the generalizability. So in summary, obviously there are a wide array of clinical questions to be answered in heart failure, and while randomized controlled trials will likely always remain the gold standard, they can't be used at every juncture just because of feasibility. Different data sets allow us to access to different types of questions. And I've gone through for you today how we used a national administrative data set to take a big picture look at national trends in comorbid heart failure and atrial fibrillation, how we used a smaller, more phenotyped clinical trial data set to look at loop diuretic use and its associations with mortality and medical therapy usage in heart failure patients with reduced ejection fraction. And finally, we looked at a national registry, which gave us access to a very specific question for a specific population and saw how LVAD patients awaiting transplant had been affected by the allocation system change from 2018. And so that's all I have for today. I just wanted to close by emphasizing that research is definitely a team sport, and none of this work would have been possible without the contributions of many other people, some of whom I've mentioned on the slide here. I particularly want to thank Dr. Desai, who's been my primary mentor through fellowship, Dr. Dan Friedman, Dr. Shunik Sen, Dr. Jim Freeman, Dr. Tariq Ahmad, and Dr. Eric Velasquez, who have all been mentors on various papers. Dr. Fuad Chouari, who was our primary statistician and who's now moved on to residency at Duke University. Dr. Clancy Mullen, who's one of the CT surgery residents here, and like I said, was the primary driver of the LVAD analysis. Former fellow, or co-fellow, now attending colleague, Dr. Elliot Miller, who's also a mentor, Catherine Clark and Bradley Kay, who are co-fellows and collaborators, Avi Guha, who is a collaborator at Case Western, Michael Fury, who's a resident here in internal medicine and has done some great work. And then finally, the fellowship leadership, Dr. Ed Miller and Parul Gandhi for all their guidance through my fellowship, and Natalia and Attila, who were my co-chief fellows, spending lots of long hours working on schedules over the past 3 years. And then finally, my wife, Dr. Tori Wesovich. So that's all I have, and I'm happy to take any questions.
Great, Sam. Thanks for that. What an outstanding presentation. I think that the breadth of it, and I think the way that you sort of walk through different methodological approaches, different statistical approaches, but all trying to answer important clinical questions, I think, to move the field, forward. So if you have a question, please use the chat function or raise your hand. We'll try and sort of get through as many as we can. And Sam, maybe I'll just kind of start and say, I think you sort of alluded to this in your concluding remarks, and I couldn't agree more as someone who's also used clinical trials data sets and been involved in clinical trials. And and also using real world data sets and trying to do real world analyses, that they are very much complementary. That, how do you see maybe those two worlds coming together a little bit? That if we think about the EHR, or we think about pragmatic clinical trials, do you see the world maybe kind of coming together where we can embed randomization into routine clinical care, if you will, to answer very relevant questions, have the rigor of randomization, but also some of the benefits, of kind of more unselected real world populations, as you kind of alluded to. Maybe give us your thoughts on kind of where you see that kind of notion of pragmatic clinical trials, and maybe these two worlds of, real world evidence and randomized clinical trials maybe sort of coming together.
Sorry, I think you broke up at the end there, at least on my end. But yeah, I think that's a very interesting question. And I do think that, EHRs to this point have still been sort of a tool for billing and not really optimized as a tool for research. And I think that they do offer a lot of promise, though, if we harness their power to try and do things like you're mentioning, sort of pragmatic clinical trials where patients are randomized using the EHR to various treatments, and we can follow them over time and have all the data available to us from the EHR for analysis. I do think that that is an area that holds promise. I think exactly how that will play out in terms of regulatory bodies and IRB and that sort of thing. And the consent process will have to shift to some degree in order for that to be made widely possible. But I do think that in general, that's an area of untapped potential. And hopefully, in the very near future, I know Dr. Desai, you've worked on randomizing providers, for example, through our health, or trying to do trials randomizing providers in our health system, looking at similar heart failure type questions. I think those hold a lot of interesting promise for the future.
That's great. Thanks, Sam. Other questions from the group?
Sam, I had a quick question. This is Lavi. So when you do your analysis in your pre and post LVAD UNOS data set, that was very good study. Thanks for sharing your results. How did you classify as high risk, and what were the criteria that you used for high risk? It's just interesting to see that the primary graft failure went up so much in the post era.
Yeah, that's a good question. It's actually, we didn't use criteria. It's the CDC has a set of criteria that I don't have memorized to classify high risk. So it's a yes, no answer that the CDC uses to classify donors. So that was
so you mean the PHI high risk?
Exactly, yeah.
The PHS high risk, okay.
Yeah.
So then what then is what are you guys speculating as the cause for such a degree in increase in primary graft failure in the post era? Because that doesn't really cause primary graft failure. That's just higher risk of transmission of infection, right? So that's
primarily. Yes. So I think that well, one, we aren't exactly sure, but I think the increased ischemic time and distance traveled was sort of a key or likely offender in that area. And we also considered the possibility that just there are other aspects of the hearts that are being accepted for LVAD patients that are maybe not captured in the database, but make them slightly less desirable organs because LVAD patients are now lower urgency status, that they have to wait for hearts to come down the list, that would put them at higher risk of graft failure. So, but yeah, that question remains not definitively answered by any stretch.
Okay, I see Arthur has a question.
Thanks. That was a great talk, Sam. I think one of the biggest questions we deal with on a clinical basis is how to manage atrial fibrillation in patients with chronic heart failure. And I think it's a high cost area of care. We have patients who spend extra days in the hospital being loaded with antiarrhythmic drugs and getting cardioversions without a clear pathway or knowledge base as to whether we're doing the right thing. We're often unsure as to, did the worsening heart failure and substrate cause atrial fibrillation, and whether or not restoration of sinus rhythm is a cost-effective and valuable path to take. So what do you think we should do to try to enhance our prospective data collection to try to answer this question better?
Oof, that's a tough one, Dr. Stelter. Yeah, it's clearly a very challenging area. I mean, I think that, national registries like there's Get With the Guidelines Heart Failure and Get With the Guidelines AFib, I think that those sorts of avenues may be helpful for those sorts of questions going forward, especially as we see likely, I think, treatment practice patterns changing in the near future based on Castle AF. Seeing, do patients in fact receive ablations, do they do better over time in the community, in the real world? And is the upfront cost of an ablation, does it end up paying for itself and reduced heart failure hospitalizations later down the road? So I think that those may be an area, or that may be a forum or a tool with which to follow such things. And then I guess we'll also see if we can, like Dr. Desai was alluding to, if we can harness EHR to design more pragmatic clinical trials, which are sort of lower burden on the patient in terms of clinic visits and that sort of thing, but still allow for pseudo randomization or randomization to different treatment patterns and following outcomes over time, harnessing the EHR in a much more robust way, not just to bill, but to actually follow patients from a research perspective.
Just like we are often asking, is the patient too sick for a TAVR or too sick for a mitral clip? Perhaps we need to ask the question, is the heart failure so advanced that going through the motions to restore sinus rhythm is a futile and high cost avenue to pursue?
Yes, I think that will be a very key question going forward. I totally agree.
Okay, we're just about up on time. Are there any other questions? All right, Sam, I'm not seeing any. Sam, thanks again for a really outstanding presentation, and great to see everyone, and look forward to seeing you all soon. Thanks again, Sam.
Great, thank you, everyone.